Fantastic. Let's go ahead and start with this very important slide. This lays the foundation and the groundwork for everything else we're going to talk about this evening, or wherever it might be around the world this morning. On the left side of your screen, what you're seeing is a cone beam file, a 3D X-ray of the jaw and the teeth. And on the right side, you're seeing an STL file. An STL file can be captured numerous different ways. You can cone beam scan a stone model. You can cone beam scan an impression. There's a variety of ways we can get an STL model. And you should very clearly notice the difference between what an STL model looks like and a DICOM model looks like. Namely, the DICOM model has quite a bit of scatter. It has a lot of scatter around radio-opaque material. A radio-opaque material like gold restoration, gutta percha from root canal fillings, and a lot of those things introduce distortion and scatter and artifact that kind of hinder us. So the way I want you to think of this is I want you to think of the DICOM data of the jaw and the bony structures mainly is used for the implant planning, so you can plot your implant and stay away from any vital structures like the nerve or adjacent tooth structures, adjacent roots. And the STL file on the right side is used to fabricate the surgical stent. So it's very important, very, very critical. The first step to do an accurate surgery is to merge these two data sets together, design the implant planning on the cone beam file, and deliver the stent with the STL information so it fits in the mouth. Now we have to, with software, merge these two sets of data together, and we have to do them accurately. We can certainly introduce errors when we merge these two data sets if we do it manually, automatically, or whatever means we reach the end result. We have to check for accuracy. If we don't, we can certainly have a stent that fits in the mouth perfectly, yet the surgery will be inaccurate. So this actually helps me rewind a little bit and let you know what the topic of this presentation is. The topic is how to perform mock surgery, whether it's manually or digitally, so that you can actually have the surgery performed on models before you do the surgery on the patient itself. So or themselves. So you can actually duplicate the surgery, have models with lab analogs in them, which has really, really big impacts. The two most common situations I like to use those for is in the anterior, so I can place the implant exactly where it belongs, and then right away I deliver an abutment and a crown to start sculpting the tissue. That's a very routine thing that I do in the anterior. In the posterior, I just let the implant heal and come back to it in 4 to 5 months and uncover and place the restoration. A bigger situation that would come in extremely handy is a very hot topic. We discuss this at a lot of our seminars and our courses. The probably #1 phone call we get at Cadre is, hey, I've never done an implant guided, and I have a fully guided, I have a full mouth case coming up where everything needs to be extracted, and I need to place 4 to 6 implants, and I want to deliver the prosthesis all through the guide, and they just don't have the basic understanding of how this stuff works. But if you know how this stuff works, you can certainly actually duplicate the surgery before it happens and fabricate the temporary prosthesis, which actually serves to stabilize the implants. When you tie multiple implants together with a prosthesis or an implant bar or some other way that keeps them stable, they actually have a higher favorability of integrating than single implants do by themselves. So you can perform that surgery digitally or manually and have the prosthesis made, and after you place the implants in the exact position you designed them, you can deliver that conversion in a short period of time, whereas traditionally, and I've seen this firsthand myself, the conversion of the prosthesis to fit to an all-on-4 type of case can sometimes take longer than the surgery. So that's the topic for today, and what I'm trying to do is establish the groundworks for how to actually do the surgery accurately. And it's really important that you understand that we need to merge these two data sets together correctly. What you're seeing on the screen now is what we used to be able to do years and years ago, which was take the cone beam data and actually draw on the cone beam data and get a surgical stent. And you can see how distorted that molar is behind where the implant planning is. You can see the holes in the jawbone. You can see how much scatter there is. And it's pretty easy to figure out. If you draw your margins on the cone beam data and you develop a surgical stent, then more than likely it's not going to fit the patient's oral condition if you just draw it off the cone beam data. This looks like it's frozen. Let's go to the next slide. So here's the view of the surgical stent on cone beam data, and there's no way this internal part of the stent is going to adapt to cone beam data. Whereas when you have an STL data, you have the implant plan, you have the ring, and you draw on the STL data, you get a surgical stent. Most of us know by now that STL data is very, very accurate. Certainly you can introduce errors in the STL data, but if you know what you're doing, it's very easy to get extremely accurate records. So what's the significance of this? The significance of this is that we need to work with cone beam machines that give us very little distortion, that give us very little artifacts. So what you're looking at is a patient that has had a full mouth rehab, and you saw how much scatter there was. In fact, I'm going to rewind that and replay it. We have root canal treated teeth, we have an implant, and you can see the scatter around these opacities that can really interfere with us when we're trying to stitch the models together. Here's the same patient scanned in another machine, an older machine, which has a lot of scatter. Older machines, I'd say probably more than 5 years ago, their sole purpose was meant to assess bone levels. It wasn't meant for all the advanced functionality we do now with guided surgery. So the lack of artifact is really important, and we get some amazing cases sent to us that are virtually impossible to create surgical stents for because there's so much scatter. Like this case here, we have the orange line, which represents the STL data, and then we have the black and white data, which is the X-ray, obviously. And you can see how in the anterior we have 6 acrylic teeth, and the STL data wraps those pretty nicely, but in the posterior we have a bunch of PFMs, and we have no idea if these models have been related to each other correctly or not. Here's a more profound view, or more obvious view from the axial, which is looking at the patient from above. As I scroll from the occlusal to the apex, again, we have orange data that is matched to the black and white data, and with all the discrepancies between them, you can absolutely mismatch these sets of data. What that means during surgery is that your odds of duplicating your design diminish if you continue with the surgery this way. Now, if you have a very big, large edentulous area and you have a crest that's 7-8 millimeters wide and you're very far from the nerve, more than likely this would be clinically insignificant. But if you're threading the needle for a lateral or a premolar and you have no room for error, I would actually not process a surgical stent off of what you're seeing on the screen. Sometimes we get cases submitted where we have stone models in this condition and we have a lot of artifact in really older machines. There's nothing we can do here, and I'll show you how to manage these more complex cases much later. So here's essentially what's happening. We have the STL data, we have the cone beam data, and we never know which is the accurate position or which is the accurate relationship between these two data sets. Is this the proper integration? If you look at these 3 different images of the models being stitched to each other, you can tell with the color discrepancy, each one of these could be accurate. You never really know, and the more scatter there is, the less accuracy you'll have when you're trying to stitch these models together. So with the advent of the new software, what's great now is we can actually take stone models and take cone beam scans of these and turn these into STL models and use that to merge with the cone beam and manufacture surgical stents that will replicate our designed for us. As you're very familiar, if you're a fan of Blue Sky Bio and you've been around for a while, there was a monumental accomplishment with Dr. Ferguson's inversion technique, where you can take an impression of a patient, and this patient is not even edentulous, and you can convert that impression into a model. And once you do that and you invert this, you have a model to work with that will allow you to merge those two data sets and create a perfectly fitting surgical stent that can replicate the surgery. Now, if you just took a cone beam scan of this patient that had a bridge and a PFM on every tooth, and you did this inversion step, you still may relate those two models to each other inaccurately. So we will probably have to introduce a reference jig, a scan appliance, something that is identical in both sets of cone beam scans, and use that as the measure of relating these two models to each other, because the discrepancy between the scatter of cone beam may vary too much compared to the STL file. So commonly what we'll see is in areas where there's so much scatter where we cannot see if the STL file is properly matched to the cone beam. We don't know how the ring's going to fit. Here's another example. This is probably the first thing I want to point out as a very good rule with this happens to us daily, is what you're looking is one arch, and the posterior we have all kinds of PFMs, and as soon as we get to the anterior where we thought we may be able to discern an accurate relationship, all of a sudden we see the opposing teeth. So now there's so much scatter, and there is the opposing dentition in occlusion that distract us from determining whether this is an accurate stitch or not. So very, very, very important. There's two things you need to know when you're scanning a patient. Number one is when you scan a patient for implant planning, you want to make sure the mouth is open and none of the teeth are touching. That'll solve half of your headaches. Number two is if you have a patient that's a tooth-borne case and they have less than 4 or 5 unrestored teeth, you're going to need a scan appliance. You're going to need that impression, and you're going to need a way to have a reference point between that impression and the patient so you can relate those models to each other. Again, let's drive the point home and make it very clear. Here's a patient with a 6-unit temporary in the anterior that's made of acrylic. The posterior 4 teeth on both sides are porcelain fused to metal crowns, and here's an older machine that scanned the posterior teeth. There's not much we can do with those posterior teeth here just from the CT scan. But when we apply the when we're trying to relate those models to each other, we can certainly use the acrylic teeth in the anterior, but you can see in the posterior how much artifact there is. And you can spend a lot of time reducing that noise with software and spending a lot of time to address that matter, but it's not worth your effort. It's not worth your time. You would, by default, go to a scan appliance in a situation like this to get an accurate result. So literally, you're looking for common places that are redundant in both sets of data so you can relate them to each other. And in a particularly heavily restored case like this, once we get to this step, I cannot tell if we've accurately related them to each other. There's just too much distraction, too much scatter, and too many things that may confuse us. Yet another example here. Yellow is the STL file, black and white are the X-rays. Again, in the posterior, we can see how it would be impossible to discern whether we've related them to each other well. And in the anterior, when we have acrylic, we have enough of overlap for us to help us. So what do we do in situations where everything is a crown? This patient, every single tooth in her mouth is a restoration. Well, we use a scan appliance, and there's 100 different ways to do these. For CEREC owners and Guylaeus owners, this is called a biplate. You could just as easily seat a plastic tray and apply radiographic beads to it, load it with PVS and scan the patient with that, and it would serve the same purpose. So in this situation, what we do for those CEREC users in the audience or the Guylaeus users is that we have the this biplate that has these radiographic markers, and gets calibrated, a lot of detail here, and ultimately it's converted into a surgical stent that you apply in the mouth, and you do the surgery. Well, we can do the same thing by using a impression tray and applying radiographic markers to get to the end result, which is what I'm going to emphasize here. So the first thing you want to do is when you're scanning somebody who is edentulous or has very few teeth, is you want to make sure your scan appliance, here it's a biplate. You could easily use a plastic tray like I mentioned, or apply radiographic beads to the PVS as it's setting. When you're setting this in the patient's mouth, it's imperative that it's seated all the way and it's adapted completely to the soft tissue. What happens frequently is the patient bites down on a holder and this scan appliance is lifted off the tissue. It's lifted off the landmarks, and you need it to be seated perfectly when you scan the patient. So sometimes we'll put cotton rolls here. We applied some napkins in the back of the mouth and ask the patient to bite down all the way so we can get a good read of what's going on. Ideally, you get a denture dupe with the final vertical dimension and the maxillary, the incisor positions and the molar occlusal positions predetermined with just standard conventional dentistry. When you're opening the vertical dimension or you're setting teeth, you want the scan appliance here. It's a denture duplicate to be radio-opaque in nature, so you can easily design and define where your landmarks are, so you know where the tooth position is, you know where to plot your implant, you know how to execute this so your implants don't end in the wrong place. Here's a case that was submitted to us where the patient moved. You also must verify that those radiographic markers do not stretch or distort so that you don't get in trouble. The other important thing to realize is when you take a denture dupe or a plastic tray with radiographic markers and you see that in the patient's mouth, you must make sure that that device is seated all the way. Here I'll show you a scan where you can see a gap between the denture dupe and the soft tissue. It's even more profound as I scroll to the anterior, and you can see how right up here on the anterior you see a gap between the scan appliance and the soft tissue. So that may indicate that the scan appliance wasn't seated all the way. Another thing you can do is before you do the surgery is you can place the surgical stent in the patient's mouth yet one more time to verify that you're accurate with your surgery. So here you can see how the draw of the tubes in the surgical stent are drawing with that initial pilot drill that this doctor made and was verifying to make sure that he was on the right track before he proceeded to do this very large case. Okay, so once that's done, then you can get a surgical stent made where you can design the implant case and you can deliver the surgery. Here I'm doing guided surgery on a dentulous patient with my Nobel Active kits, but I'm using the Biomax implants to precisely deliver the implants where I've designed them with the Nobel carriers. So I'll give you this in much more detail later on. So here what you're seeing are 6 implants. These were Biomax implants by Blue Sky Bio with the impression copings in place, and I just want to point out how parallel that is. That is not from any special skills that I have. That is all software driven, where every single implant is perfectly placed parallel to the next one, which makes restorative really, really easy. So I'll get to that in more detail in a bit, but I wanted to make sure we were all clear on exactly how to image a patient and how we get to the point where we can do precise surgery. So this first segment was on the multiple ways we scan to assure us a precise surgery that duplicates our design. So we'll just, as a quick review, if we're doing tooth-borne cases and we don't have too many restored teeth. With restored teeth, what I mean is PFM, gold, root canals. Ceramic crowns are actually just fine, like EMAX. But gold and PFMs have a lot of scatter. That's the first category of patients. Second category of patients are heavily restored tooth-borne cases where you cannot rely on the STL and the cone beam merge. And then the third case are edentulous cases. So or cases that the patient's going to have a full mouth series of extractions, and we get cases submitted like this where the patient's cone beam is submitted with absolutely no reference points. There's no scan appliance in the mouth. There's no denture duplicate. There's no impression tray with radiographic markers. And you absolutely need those things to proceed with the surgery to do it accurately. So here's a example of a denture dupe that we have with radiographic markers on it. And it's really important for an edentulous case that we're doing that the vestibules, or the depth of the vestibule in these denture dupes or scan appliances, reach the depth of all the tissue you have to afford in the patient's mouth, because those could be used for areas where you could use them as anchor pins. So we want radiographic markers. Actually, ideally, you prefer them to bulge out, and Blue Sky Bio has these little radiographic markers that you can use as a sticker that you place on the denture dupe. But you don't want our denture dupes that are short of the vestibule, like here. You can see how much more landmark you have that you can grab with this denture duplicate that would show you exactly the depth of the vestibule, because like I said, you may need to utilize those areas for the identification of where areas of anchor pins might be. So once we digitize that denture, the internal of the denture, by scanning it with cone beam and relate it to each other, we can now design implants and fabricate a surgical stent like this very economically, where we can produce very, very accurate surgery. So very important that everybody understands that. And
something that we get questions about a lot is, how do you physically position the model in the CT scanner, and how do you support it properly so that it gets scanned properly and nothing else gets included in the scan?
Very, very common question. It depends on the machine you have. I work with a lot of doctors who have the Galileos machine. They give you this cylinder, and this technique is actually quite old. So scanning the denture with the cone beam has been around probably a couple of decades. It's called the dual scan technique. But everything I'd seen prior to what Blue Sky accomplished was terrible results. It was very unworkable. It was nowhere near as precise as we have to work with. It's the software development. So actually, this is a perfect place to show you. You can place it in here, and it depends on the size of your machine or the field of view of your machine. If you have a large field of view, I can place my plaster cast or impression pretty much anywhere, and it'll pick up that impression or that scan. But if you have a smaller machine, you may have to really find that perfect position by scanning it multiple times and marking it, and have some kind of reference point so you can constantly position it there. But for the Galileos owners, there is a tin can that was given to you for the purpose of scanning dentures and stone models, and it comes out very, very clean. So you can scan the stone model, you can scan the impression as well. Realize when you do this, you do lose the luxury a little bit. It's not that significant. It doesn't make that big of a deal, but you do lose the luxury of being able to design a tooth that's in the perfect position, a digital wax up. It takes a lot of effort to scan the opposing and relate the models to each other and do a digital wax up. You can do all that within Blue Sky, but it's quite a bit of effort. So what I'm getting at is, if you have a patient where they don't have any malocclusion, where the adjacent teeth haven't collapsed into that space, there's no supra eruption from the opposing teeth, you can just take a single arch impression like this and cone beam scan it. But if you have a collapsed bite and you have some concerns, you should actually have it waxed up, maybe by a lab, to the contour, and then the cone beam scan that. Or actually, ideally, you should do ortho to position the teeth in the right spot so that you can perform the surgery and get the most ideal result. So what I'm showing you here is exactly what summarizes or brings things together. So remember I said in the first case, the tooth-borne cases, we have the teeth that we relate to the cone beam images with the STL and the DCM. But here's a particular case, and I'm hoping this drives a point home, where every tooth in the upper arch is restored with some kind of metal restoration, a PFM. So the restorations above are occlusal or higher, supra to those 8 radiographic markers, have a lot of scatter and distortion to them. You can play with the density here and intensify it and get some more resolution, but they're very unreliable for relating the cone beam data to the dentition. So what we're doing here is we're using that jig that I was talking about, the scan appliance with the radiographic markers, and or the impression scan with the radiographic markers. And instead of using the teeth to relate to the models of the cone beam and the STL, we're going to use those radiographic landmarks. So it's really important that those don't change position while you're transporting them or sending them to a lab or sending it to somebody else to scan them for you. Really important you don't lose those radiographic landmarks, or somebody doesn't scrape them off before you cone beam scan it. So what you're seeing here is a case where a patient was scanned with a scan appliance with the radiographic markers, and you're seeing a cone beam scan of a scan appliance with radiographic markers as well. So this is the jig we're talking about. Those 8 markers are going to be used to relate the scan appliance to the cone beam data that also had the scan appliance in the patient's mouth. If that scan appliance, like I've emphasized so many times already, was not seated all the way, and you go to this step, you can have the most perfect design. You will have a surgical stent that fits perfectly, yet your surgery can be completely off. So while this is going on, I want to reiterate, make sure there's no movement to the patient. Make sure the patient patient's scan appliance was seated all the way, and there was no errors introduced into the equation. And make sure you have enough landmarks. One thing I didn't emphasize, with the landmarks, when you relate these to each other, most cone beam machines take 14, 15 seconds to scan a patient, and they may be still for the first 13 seconds and have no movement, but maybe for the last second or two, their shoulder, the machine bumps into their shoulders and they move. So 1 or 2 of those radiographic markers will become distorted, and you might be able to catch the fact that they moved. So what you're seeing here is the well-documented Ferguson technique that we're all going crazy over. You want to make sure that there's no holes in the PVS impression, so you play with the intensity levels. So this was that biplate that somebody used with a PVS impression material, and we already suspect some trouble in the area of 8 and 9 or the centrals. But in the posteriors, we have impressions of teeth that could serve as good landmarks for the surgical stent to fit. Now, ideally, preferably, you'll have flanges to the scan appliance that will allow you to have a much better adaptation to the teeth and have no slop factor and not introduce any errors. Basically, a plastic tray that you take a PVS impression with would work just fine. So this is the inversion technique that we've been talking about. And when you place a line, you can clear it, you can edit it. You can see I swerved a little bit, and you could just hit edit curve and correct that and redo it. You hold the shift button down and then use the trackball to correct that line. And then once you're finished with the correction, you click on the create invert model. So let's redo that. This was unnecessary. Instead of having erased that line, I should have just hit edit curve instead of clear curve. No big deal, but we'll proceed. And you can already tell from this image that 8 and 9 are going to be a little bit distorted. There might be some, might have some trouble with that. But if it's completely covered with PVS, you won't run into that. And already, since I recorded this last week, there's been significant advancements. Hiroshi has already come up with a way to calibrate this by putting pins on the tray so that you can measure and make sure you're at the right intensity. So ignore the artifact you see around the centrals. We're just playing around. But the posterior teeth certainly can be used for stability of the surgical stent, so that we can place an implant on the side of 7. Obviously, that artifact around 8, 9 you can just crop out. You can edit it out and remove it. And now we have the same thing. We have teeth, we have landmarks, and we have multiple ways now where we can relate models to each other. So I'm going to slow this down a little bit. For instance, now, since we have the same information, we've related one model, the scan appliance, to the DICOM, and then now we can even use advanced features like the direct and align to the cone beam, hit OK, and it perfectly lines things up. So this is actually a tougher case, a more difficult case than an edentulous case. These heavily restored ones are very, very difficult, but a surgical stent made off of this brown model with 8 and 9, the centrals removed, would give us actually a very precise surgery, minus the issue with the central incisors. So I'm just trying to show you how we can now relate multiple different appliances to each other. So again, another good opportunity to take a little break. Again, Michael, I'll stop and let you address any thoughts or any questions that have come up. I'll grab a cup of water and see if there's any questions.
Yeah, a couple questions. Have you seen a difference in the quality between a surgical guide fabricated based on PL scan and a surgical guide fabricated from a CT scan?
That is a very fair question. The best way I can answer it is you pretty much have to figure out the exact setting of your machine and the material that you used. And I think that's the phase we're all in. Michael, you can chime in because you have more experience with this than I do. So basically what it comes down to is how you scan your impression material, how you scan the stone model. And I have multiple cases now where I've gone back. In fact, if you guys can see my screen, let me pull up a good one for you guys to check out. So can everybody see the website? Michael, can you see the Academy website?
Yeah, we see it.
All right, so under online curriculum, what I've posted here under practice is the DICOM data for this particular case. We have the STL data, and then we also have the DICOM data of the stone model. So what you can do is go ahead and load the Blue Sky Bio software, download the STL, download the stone model, and then play with that intensity threshold and see exactly where that setting is. And literally on an hour-to-hour basis, the stuff is being improved upon, and we're finding the correct settings to use. And that was a great observation. In fact, the reason this last case that I showed you looked like it did, long story short, it was a person who couldn't utilize a service in Germany and asked me to do him a favor. And if you look at the scan appliance that he used and the PVS, that the teeth actually perforated through the scan appliance, through the PVS and touched the scan appliance. So ideally, the PVS completely surrounds the teeth, and you don't have any teeth perforating through the PVS material. With enough calibration and with all the developments that are happening lately, they can be just as accurate, if not more accurate. I would say you will have to spend just a little bit of energy with your machine. There's, I think, as of now, over 60 different cone beam machines. They use different levels of exposure, we all use different PVS materials. Very fair question, and the fairest answer is you will have to play with the machine and find the settings that work best for you. And figure out what those settings are and always scan the same exact way. All this is happening. Actually, all that is old news. We've already had serious improvements and advances in the last couple of days even. So it's changing rapidly, but for sure, 100% once you scan the cone beam scan the PVS and the stone model and you figure out how to calibrate it and set it at the right setting, then you will have very accurate results. Like I mentioned, Hiroshi just very genius move on his part. He printed a block with 4 cylinders on it at different heights, and he knew exactly what heights they were. So he places that in the machine before he scans it with the impression tray or the stone model. So he basically has a point of reference that he can calibrate the accuracy of the cone beam scan when he measures it against those points. It's a really brilliant way, very easy way to get to it. So basically, it's just like the old school way of putting radiographic markers on a PA that you knew were 5 millimeters in diameter, and if they were, a bit wider than that, then you have that factor that you would divide that number by to measure a distance on a 2-dimensional X-ray. Same concept. Is it fair to move on?
Yeah. Just to clarify, this needs to be done. You want to find the proper settings for your CT scanner, and you want to find the proper density threshold with that slider that appears underneath the 3D view. But once you have those settings and you're doing cases consistently the same way, obviously this doesn't need to be repeated on a case-by-case basis. You just want to find the proper settings and use them regularly.
Exactly.
Another important point, which you touched upon, is just to make sure when you're creating the impression that the material completely surrounds the relevant areas. You don't have any holes, you don't have any parts with a thin amount of material. In order to get a proper impression taken and to be able to reverse it properly, you want to make sure you have a sufficient amount of impression material all the way around.
You do not want the incisal edges of your anteriors touching the tray, as opposed to there being PVS material between the tray and the teeth.
Great, I think we're good to go on.
All right. So first, part 1 was to talk about how to accurately scan patients and how to accurately relate models to each other and what to look out for. Quick review again: make sure the patient didn't move, make sure the patient's mouth was open. If there's more than 5 or 6, if there's less than 5 or 6 heavily restored teeth, you will need to use a scan appliance. There's 100 ways to do those, and I just showed you a handful. There's 1,000 shortcuts. Now we got to move on to the delivery of the implant system. And what I'm going to do is I'm going to save you quite a bit of money and headache here. I'm going to detail here about $50,000 worth of instrumentation mistakes that you don't have to repeat. So about 7-8 years ago, I got into guided surgery. And what you see in the top left corner was my first Astra kit. That was worth about $12,000. But if you buy 800 implants, you get that tray for free. And what I didn't like about this system is it has these keys and handles, and it made surgery in the posterior of the mouth extremely difficult. Access was a nightmare. So I did the next brightest thing. I figured this didn't work. I bought another kit. I bought another kit for $9,000, a Nobel kit with, again, a bunch of handles and very long drills. There are drills that are humanly impossible to get into somebody's mouth. Then my journey led to other type of drills that do not use keys. Here's one type, the direct cut drill from Blue Sky Bio. There's another one that doesn't use handles and keys. There's many, many out there. Most of you are familiar with probably Emil Verban's drills with the stops. You have multiple options, but the beauty of that is it makes access very easy. And what's great for most of you, if you're already within the Blue Sky line, is that you're avoiding this. The surgical stent, the handle and a long drill in the back of the mouth is an absolute nightmare, and it can ruin your day. It can ruin the whole afternoon, because I had cases early on, 6, 7, 8 years ago, where I could not fit the surgical stent in the patient's mouth with those handles and those drills. It was a very frustrating exercise. So I'm going to take you through a sample kit. This is the Straumann kit. I mean, it looks so overwhelming and so scary when you first see it, but it's actually rather easy. So let's take a look at the system. The system has a sleeve position that can be placed 2 millimeters, 4 millimeters, or 6 millimeters above the implant. The height of the sleeve is 5 millimeters, and the diameter of the sleeve is 5 millimeters. Okay, so those are the options for the Straumann kit. Then you have drills that are short, long, and extra long. Their overall lengths are 32, 36, or 40. Their guided lengths are 16, 20, and 24, and they're designated with a symbol with 1 hash, 2 hash, or 3 hash marks. Take a look at that overall length of 40 millimeters. It is impossible to get a 40 millimeter drill in a patient's mouth in a second molar area. And then you have these handles that have the +1 or the +3 that change the height of your osteotomy accordingly by raising the position of the stop by 1 or 3 millimeters. So here's a little slide I showed every lecture. I'm going to ask you in the bottom left corner, let's say we have a 10 millimeter implant. You have 4 millimeters of space between the implant and the bottom of the sleeve. We know the sleeve is 5 millimeters, so that's altogether 10 plus 4 plus 5. So if you wanted to do the surgery here and end up placing a 10 millimeter implant, you would use the 20 guided length drill with a +1 handle. So 20 plus 1 would raise the depth that you reach of that drill by 1 millimeter, which will allow you to place a 10 millimeter implant with those settings. Another option is to raise that sleeve by, to 6 millimeters, use a 24 millimeter guided length drill and the 3 millimeter handle. So it's very simple, and that's actually all the cases are designed for you when you have control over it with the Blue Sky Bio software. Now, a really important point I need to make that many would probably not even understand or appreciate is literally until Blue Sky Bio software was launched, up until that point, every surgery was designed specifically to accommodate the surgical kit that we used to buy for $8,000 to $10,000. So it was the complete opposite approach. It was designed by engineers and had no dental input involved whatsoever, and it made surgery very difficult because you would plan the case so that you can accommodate the surgical kit, as opposed to planning the case for ease of surgery and then using the appropriate instruments to deliver that care. And that makes a big difference. It makes your life so much easier. It makes the most complex surgeries super easy. So I'm going to give you a quick review or a preview of the type of guides you have available to yourself. This particular system is very much like the Blue Sky system, the direct cut drill. There's no sleeves and handles. The whole surgery, all of it, is done through the stent. Here we have to use a drill extender, and the implant is also placed fully guided. The implant is seated through the stent, and you have these stops on the carrier, and when you reach the bottom of the stop here, as you're torquing it down, when you've reached the bottom, you are completely seated. One common error some people make is when they bottom out, they keep torquing like I am here, and they strip the bone of all the grip that they had. So that's called fully guided. Everything is done through the stent. This particular case you're watching is called a pilot stent. With a pilot stent, you only use the first drill, and after you use the first drill, you take off the surgical stent, and then you use bone expanders. You do everything else freehand and place the implant in freehand. And then you have multiple other options, which are utilizing multiple different stents or having different sleeves that you pop in and out. But those are the most popular. They're the pilot stents and the fully guided stents. Now, the pilot ones, for an inexperienced person, or even for me, I've placed plenty of implants, I still prefer to do everything fully guided or as close to fully guided as possible. A novice person really loves fully guided because he or she has their hands held throughout the process as they're going through it. With a pilot one, as soon as you take off the stent, you can absolutely end up in the wrong spot. There are implant systems out there that have very aggressive threads. You can create the osteotomy going one way, and when you place the implant freehand, it can go a completely different direction. So very important statement I'm about to make. The only way to accurately place the implant exactly or as close to exactly where you've designed it is to do it fully guided. As soon as you go away from fully guided, your odds of placing the implant exactly where you designed it will not get you there. You could certainly introduce errors and get in trouble that way. I want to make sure everybody understood that, so I'll pause again to see if there are any questions.
No, there are no questions at this time.
Okay, let me just grab a sip of water and we'll proceed. All right, so again, as a review, the only way you can place the implant exactly how you designed it is to use a fully guided system. Because when you use a pilot one, this is one of my favorite slides, you use a pilot drill, you take the stent off. When you go to do the subsequent drills freehand, you're supposed to symmetrically widen the osteotomy. When I do it, I end up somewhere like this. It's not a symmetrical widening of the osteotomy. So what I'm going to take you through is a case where I designed this, and while this is happening, I'll explain this to you. The Blue Sky Biosystem right now is a keyless system, which is great, but it's not fully guided because you have to take off the stent and place the implant freehand. Within the next 2 to 3 months, I believe, if I'm not mistaken, they will have a fully guided option. So we're all very excited about that. We're excited because we can place all of their implant lines fully guided. So what I'm doing here is I wanted to use the Blue Sky Bio Conus implant, which has the same connections as my Astra implants. And I have all kinds of Astra equipment at this point. When I did this is quite a few years ago. I've got all the prosthetic components, and what you're seeing is a patient who had primary retained canines, and one of them was ankylosed. The one on the lower left we actually decided to leave alone. And the oral surgeon removed the other 3 impacted wisdom teeth. And one of the things that works really well is with the implantology, there's always or generally a space discrepancy from the adjacent teeth migrating into that position. You're not having enough space. So my wife is a dentist, and we work together. So she did the Invisalign here, and she spaced it out for me so that I had enough room for an adult canine in the upper. And the lower jaw, we kept that primary canine and left the ankylosed canine in place. And now we're looking at the case where we're planning it for the conus. So this is months after the removal of the impacted teeth, and I'm going to plan for the immediate extraction of the primary teeth and the placement of the implants. So what I'm doing here, and what you're seeing on the screen is I'm using the CIREC camera, and you can do this again by scanning stone models. It's completely up to you how you get to the final approach. I have the upper jaw I scan in the lower jaw. Again, you can mount these on models and have the lab wax it up, stick it in a cone beam, and get to the same end result. And we finish the case and we relate the upper jaw to the lower jaw. And from here, digitally, we design the restorations for the place of the canine and the upper left and the upper right canines. Now I'm going to import these and relate them to the cone beam, and I'm going to have the restorations in place. And now I'm going to go ahead and place the implants. And in this particular software, the Galileo software, I'm going to use the Astra line because of the conus replicas. So I can see the position of it, and I know exactly where the sleeves end up in this surgical case. So remember, there's sleeves in the stent, and those are going to dictate my final resting spots or stops for the implants as I'm placing them. So again, to reiterate, I'm doing this in this manner with this software a few years ago because I wanted to use my Astra fully guided kit to place a conus implant, and I need to know where the sleeve positions are going to be. So not only do I do that, but I also can see here, this is the whole beauty of having cone beam and designing all this stuff in 3D, is that I saw that I'm going to have a gap facial to the implant after we remove the primary canine. So the surgical stent is returned, and this particular system from Astra, the replica of conus, has a carrier of 9, and there's a lab analog for that implant, and then we also have markers that show us exactly where the walls of that connection is going to be. So on this surgical stent that I have, and on the model that I have, I'm going to do mock surgery, the title of this presentation, where I'm going to create or replicate what's going to happen a week from this point before it happens. So before I even touch the patient, I will have a very nice model that accurately depicts how the surgery is going to end up. And what that allows me to do in the anterior is pre-make abutments, engaging abutments if I wanted to, and pre-make temporaries so that I can start sculpting the tissue right after the implant placement. Obviously, you're worried about loading the implants too soon. You're worried about the patient biting into it. That can always be an issue, obviously, but you manage that with the patient and let them know that they're going to continue wearing their Invisalign trays as protection. They never take them off so that we don't place undue stress on these implants. So now I've got the implant carriers, placing the implants in this model, holding them in place with PVS. Ideally use something more rigid like some kind of acrylic or Duralay. And here is what the surgery is going to look like. The surgery is going to have my conus implants placed exactly at that spot, and the slash marks that you saw in the surgical stent are going to indicate where the walls are for me for indexing. So then I scan the abutment with restoration. There you can see the CEREC temporary made out of feldspathic ceramic. And let's go ahead and do the procedure. So for the procedure itself, I'm going to do the extractions, which are pretty straightforward, just being very gentle, not to break any bone. And here was the plan for an Astra. It was supposed to use a 4mm diameter implant by 15mm in length. I was supposed to use the twistal key height, the 25mm drills, the 2.0, 3.2, 3.7 drill as I widened the osteotomy. The 3.85 was optional, and I'm using implant holder size 9. There's a 7, 9, and 11. And here are all the drill sets, as you can see, the 25 drill sets, the 22, the 18, the 14, from 2.0 to 3.2 to 3.7, all the way up to 4.7. And here are all the keys with different heights to them, and very, very cumbersome process and easy to make a mistake. But we're going to go through the sequence that that table showed us. We're going to go ahead and place the first twist drill key, which is 1mm in height, and we're going to use a 2.0 drill. And what is great about these is that it keeps me on track. I don't bounce off the bone. I don't do any damage. And these drills, when they're guided, they're held very tightly approximated, and they stay on their own track, and you don't run the risk of breaking off a chunk of the buccal bone as you're drilling freehand. So you can really guide this with a pinpoint precision. So I'm going all the way until I bottom out, and once I bottom out, all the math is done. The position of the sleeve is in a very deliberate plane on the X, Y, and Z axis, so that when I use this key that's 1mm tall, with this 25mm drill, when I bottom out, I've gone to the depth of the geometry of the prep. Okay, so after the 2.0, we do the same thing. We're going to expand the osteotomy now with a 3.2. Here's a 3.2 drill, and we expand the osteotomy, and then again we go to depth, and then we're going to do it with a 3/7 drill. What I'm doing here is I'm actually running the drill at 50 RPMs with no water, and I'm going to harvest that bone. And I'm going to harvest that bone. If you remember in the 3D X-ray, we saw how there was a gap between the implant and the bone. So this is going to fill in that gap for us. So we're harvesting. Then we're going to place the conus implant that was 15 millimeters long. And remember, this is from a few years ago where conus did not have a fully guided system. And we place the implant all the way so it goes to depth. And then now we disengage the carrier. The carrier can sometimes mechanically lock into the implant and disengage. You have to disengage it so that it doesn't rip the implant out of the stent. So let's do the same thing on the left side. We'll start with the 2.0, the 3.2. You go to depth and you bottom out. Once you do that, you've gone to the depth of the osteotomy. And you want a pumping action with the drill so that enough fluid or enough saline gets in there so the bone doesn't necrose. So here's the same approach where I've turned off the water. I'm going at only 50 RPMs, and I'm harvesting the bone that I'm going to use for grafting purposes. So this is the amount of bone we literally wash away when we're doing an osteotomy. That could easily be utilized for grafting purposes. There's quite a bit. Show you that. All right, so put that in a sterile dappen dish, and then we're going to come back and fill the gap in with that bone. And here's the conus, again, on that 9 millimeter carrier. And once the carrier and the stent engage, I don't run the risk of veering off track. I'm just, the tube in the surgical stent and this implant holder approximate very well, and I'm going to use the driver to seat this all the way. The one thing you do have to pay attention to is when you seat this all the way and you have bottomed out where your carrier has touched the sleeve in the stent, I mentioned this before, you want to refrain from over-torquing this. You want to stop when you've bottomed out. If you over-torque it, or you bottom out and you keep torquing away, and you complete one revolution, you have now stripped all that bone that you engaged while placing the implant. So here I'm trying to get that white dot to match that slot in the surgical stent, which will line up my configuration, the internal connection of the implant with the prefabricated abutment. So we're going to go ahead and disengage this. There's a screw you have to take off, and then you disengage that carrier. And here's exactly what we're talking about. We had a gap on the facial, but on the palatal, there's bone. There's a gap on the facial. So we're going to take some of that harvested bone and graft it to the facial of that, very minimal grafting. And ideally, you put the cover screw on and then do this so it doesn't go down the well of the implant. But it worked out just fine. And you remember there's gum tissue, bone, grafted bone, and then the fixture. So I don't really need a membrane. If it was gum tissue, grafted bone, and implant, then you'd have to place a membrane over that. And I don't need to cover this in any special way because the abutment that I'm about to place is going to hold everything in place and seal it up and not let any of that bone move while the patient's healing. And here's how I carry the abutment. The conus has multiple walls, and you could easily engage the wrong wall. I'm going to use my temporary to carry the abutment and place it in the site. And there's the screw you can see from the temporary. It's just helping me with indexing the abutment. So I make sure in the temporary phase I use a metal abutment here, and I use a translucent ceramic. I'm going to make sure the patient comes back for an EMAC so I can hide that metal. And as mentioned before many times already, the whole purpose of this is to start sculpting the tissue. So the abutment is seated. It's torqued down with finger pressure. I don't use a torque wrench. There's a temporary. I verify the seat, and I'll cut off the screw and polish it and seat it and do that on both sides. Okay, we'll take that off and do the same thing on the other side. And we'll verify with the x-ray that everything is seated. And here's immediate post-op from the surgery. This is right after the extraction. And the way we do this is my wife plans the case, and when she's done moving the adjacent teeth in space with the clear aligners, she lets me know, and that's when I place the implants, and then the patient continues with their Invisalign therapy, and the timing usually works out so that when they're done with the ortho, I'm ready to place the final restoration. So this is 1 week post-op. You can see how healthy the tissue looks. Again, those are temporary feldspathic ceramic, and they look gray because there's metal underneath them. That's deliberate. Here is about 5-6 months post-op, where you can see how healthy the tissue looks, and we're ready to restore them. So let's apply the same principle to a fully edentulous case, and this is the whole purpose of this presentation. What I love about this is we can replicate a very large, complex surgery with 10 implants if we did it fully guided, and have models made so that we can pre-make the prosthesis, so we don't have to do that conversion I alluded to at the beginning of the presentation. So here we have a patient that has in complete dentures. She's at her ideal vertical dimension, and the teeth position are to her liking. So we duplicate the chair side with Corey Glenn's famous technique of duplicating dentures. And what I should have used instead of a clear acrylic was a radiopaque acrylic. I didn't have any at the office, but I knew if I scanned this patient with this denture duplicate without any opacity to it, it's a useless scan. I'd have no idea where the teeth are. I have no idea where the extensions are. So I just applied some flowable composite to the incisal edges and cured those. They were expired composites. And then I seated that in the mouth. I relined the internal of the denture dupe. I applied it to the scan appliance that has radiographic markers. I made 2 scan appliances. Remember, there's 1 trillion ways to do this. You can use a impression tray and put radiographic beads on it yourself. And then we went on to the design of the surgical case. So what I have here are 6 lower teeth that are designed as Nobel actives, but I'm going to use Blue Sky Biomax instead. The uppers are designed also for Nobel active. 2 of the 2 anteriors are almost parallel to each other. The 2 distal ones are flared are tilted at 30 degrees. And here are the surgical stents. If you're OCD like I am, I recommend you put these surgical stents in the patient's mouth and scan them 1 more time before surgery and verify the path of surgery just to make sure you haven't introduced any errors. So now we'll go through the process. The patient is intubated and sedated. I've brought an anesthesiologist in the office. I'm using a tissue punch that also removes some bone. I do that first before anchoring in the anchor pins. I want to make sure that the stent is seated all the way, because sometimes those rings can end up where the tissue is. So by removing the tissue, I make sure the stent is seated all the way, and now we have windows also that are in the exposed to us where the tissue is, and I can make sure this is locked into place and I can proceed with the surgery. So this particular system that I use, the Nobel Active, that has the same connection as the Biomax, uses drills with handles. In the anterior, it is not a problem at all. And you can actually place stops on these, and those markers are for the 7mm implant, the next marker is for the 10, and then the next marker is 13, so between those 2 lines is 11.5. So you go to depth and you widen the osteotomy here. Again, the patient is intubated, the anesthesiologist has them out, and we can go ahead and work. So the first 2 implants, placing them was very, very easy. And the posterior implants, particularly for the upper that are angled 30 degrees, that was not easy, simply because of access. So I'm not an oral surgeon, I'm a general dentist, and I don't do many of these, but all the work went in the preparation for this so that the surgery is really, really easy. So here are the Blue Sky Bio max implants, and I placed them in, and I'm going to torque them down. And again, with that carrier, when I bottom out, I have placed the implant exactly where it belongs, and I have not gone off track. And if I wanted to, I could also make sure the internal walls of my internal connection, the conical connection, are also lined up properly. So we'll torque this down, and again, when we bottom out, we are finished. And you want to refrain from overdoing it because you can strip the bone. Okay, now this patient is sedated. If they weren't sedated, I would take off those carriers because in case they start coughing or gagging, I want to be able to take out the surgical stent right away. So if you left those in, there's a chance that they might rip those out as they start gagging or choking. So ideally for me, I like to take them off. But since she's out and we have a throat pack in there and anesthesiologist is monitoring her airway, I'm not worried about that. So you notice how the distal one is much harder access, but we're finished with the upper jaw and the upper 4 implants. Okay, go ahead and clean up her throat, and we'll do the same. And here's one of the most important points of this whole presentation is I struggled so much with these drills. You can see me struggling with that second, the most distal there. I don't have a stop on this, so I can easily slip. That's also dangerous, but you can see me having a hard time getting the drill out of the patient's jaw, and luckily she is completely sedated. The most distal molar here, that particular surgery took longer than all 4 uppers combined. I'm really, really struggling to place that drill and get it in the mouth. So I'm hoping you really understand the difficulties involved with using systems that use handles and keys. Very, very difficult to manage, and that's the beauty of the single cut drills from Blue Sky Bio is you don't have to deal with that. And even if you had a case that's designed for the long drill, start with a short drill, get a purchase point, and then go to the long drill to continue the placement. So let's fast forward this to at Uncovery. Here's another 3D X-ray to verify everything. And as you saw, those lower 6 implants as a preview when I started are perfectly parallel to that. That's not my hand skill. That's all software, and that's all doing all the procedures, all the steps correctly so that I can deliver that. And we're able to perform the surgery so that we can easily pick up this impression, and there'll be no distortion in this. I'm going to go ahead and adhere them to each other so that we can pour this up and have an accurate representation of what's going on in the patient's mouth. So we'll fast forward to the finished product here, leaving out some steps here because I'm going to get to the software. So here are here's the upper jaw with the multi-unit abutments correcting the angulation. Here are the multi-abutments from Blue Sky Bio. And then we had them fabricated into the hybrid for the upper. We do the wax try-in. Here's the perfect fit with the platform switch of the multi-abutment that's angled to the distal ones. The anterior ones are the straight multis. Here's the distal one that's a multi-angled. Lower one is also seated with 2 screws holding in place. So I'm checking out the lip support, the tooth position, and then they're finally converted into the prosthesis. And on the day of delivery, the upper jaw is in multis, the lower jaw is actually in an overdenture, long story, but we'll apply those into the patient's mouth, and we have upper hybrid, lower overdenture. The main reason I went with a lower removable overdenture is because she lost her teeth to advanced periodontal disease, and she builds up a lot of tartar and calculus very quickly, and I wanted a removable device so that I can take it out, or she can take it out once in a while and clean it, although that 6-unit overdenture is just as much of a fixed appliance as anything else. So what I want to show you in the software, first thing I want to draw your attention to, I just downloaded this. This is the Mac version. So first thing you want to do, let's hide the arch here, and we're going to go through this axial view here. And I'm hoping by now, with everything I've been discussing, that you guys who are watching this, that you can tell that there's a discrepancy between the orange STL and the white CAD-CAM line. It's very hard to do with a mouse pad, but let's go to the points and let's click on align to model here again, and or I'm sorry, align, and let's straighten this out. I want to see if you can, if you'll notice a difference. So very, very critical that we line these up properly. So let's point out all the appropriate landmarks. So molar, premolar, premolar, canine. Let's flip it around, do the other side. So very, very important that you pay attention to this. Even if you do it automatically, you want to verify. And sometimes it takes just 1 point to make all the difference in the world for these to fit better. You see how it changed? It's still not fitting better. It's not dead on stitch, so you have to pay attention to that and get it done correctly. So what I'm going to do is just a very, very quick demo. I'm going to add a tooth here. Let's make sure we pick the mandible. Let's go with Biomax, and let's pick a size that's a 4.3 or a 5.0 by 11.5. Let's hit OK. Let's drop it here, and let's position it real nicely. And the only thing I wanted to show you in the software is how you can, let's assume you're happy with the placement of this implant. It's where you want it to be. You can obviously change it, fine tune it, place it deeper, make it wider. But all you do is you go to the file and you create the analog holes. When you click on that, you can get an STL of the model that will have the holes in it so that you can place a lab analog and replicate the surgery. But again, realize that it will only be close to accurate if you do the surgery itself fully guided. Guide tubes visible and then create holes, right? That's right.
Yeah.
Thanks, Michael.
Let me read out to you a question that came in while this is processing.
Yeah.
For a full arch case, a bone reduction might be needed. How can you do these cases fully guided?
With bone reduction?
Yeah, if bone reduction is necessary, how can you do it fully guided?
Yeah, you would make complicated to explain on this. We have videos on it. You have multiple choices. You can do a bone guide. Well, you have to segment the cone beam scan. You could actually do two separate guides, and what's great now with guides being so cheap, you can have one guide made so that you do the surgery and place the implant, and you can have another guide made so that there's a window cut out so that you can see the exactly where to cut off the bone to make that happen. So you would make multiple guides, make it do it in that fashion. There's your lab analog, so you can print this and get a lab analog and place it, and it does have a hole in it from the back, so you can pop it out as well. Just remember, this will only be accurate if you do it fully guided. So let me turn this off because I know my computer's about to crash. All right, let's see what other questions there are.
There's been a lot of questions and interest in the Blue Sky Bio Academy. Can you give a brief overview and explanation about what's involved there?
Sure. That must be one of the Academy faculty members who asked that question, because that's a very easy softball, whoever threw that at me. Thank you very much. We have the Academy website you can see on the screen. Our goal was to have as many different languages on this site as possible. So we have a formal educational tract, an online curriculum that'll have the software, you have practice designs, you have surgical cases, and we're preparing for future ortho software and guided endo. You guys probably saw what Hiroshi did. So when you register, and what we're doing right now for everyone is when you go to log in or register, actually let me do it officially here. When you go in to register for this, we're charging $550 for 1 year and $300 for each following year. But everyone that signs up now until we're fully launched, we're in the soft launch phase, we're going to add 6 months to their membership, and there's a code that you can receive that will also give you $50 off. And our goal is to document everything we can possibly do with the software. So we have courses that we do, hands-on courses. Just had a great seminar in Seattle. A good number of you were there. And we have the online curriculum where here we have the guided surgery principles, a good summary of the stuff that I discussed today. So if you need to review it, it's all there. We have under the online curriculum, we have imaging principles. These are all the I've seen thousands of scans by now, so it tells you, it teaches you how to scan a patient, how the stents are made, kind of a review of today in more detail. And then we have the surgical software, and it has the introduction, it has all the features in the software that you'll be able to use, the different type of cases that we have. And I know we have an international audience now, but what's really awesome is I can click on this view, the tangential view in the software, and you can watch it in multiple different languages. So we have a awesome list of faculty members who will be doing this in Russian and Japanese and Spanish and multiple languages. And then we also have these tracks or these curriculums. I'll just show. We have Marco and we have Christian Brenes working on his in Spanish. But ultimately, what we wanted to do is have it be basically a book that each one of us writes. And I love using CAD/CAM and cone beam, so there's different tracks of information. Has all of my latest published articles and videos on the website. The meat of the substance is obviously the online curriculum. And we have a great group of guys helping out with Bear and everybody else. And we have a discussion forum as well, where you can ask questions and practice cases and ask us anything you need. So we have a great support system. We're of the belief that this software just, excuse my language, kicks so much ass that we're absolutely committed to providing a great resource and support for the many doctors who'll be using it, because right now we're doing things that used to cost $800, $700 just a year ago, and we can do them for $30, $40, and it's pretty much the biggest revolution in dentistry. It's the biggest advancement. My goal with when I started Cadre and got into this blue sky stuff is to get every doctor to be able to place an implant fully guided at a profit margin, instead of spending $50, $60, $100,000 and not seeing an ROI for 2 years. They can place an implant fully guided from the very first one that they want to do. They can start off that way. So it's a very different world we live in right now, and I'm super excited about that.
Very good. I'd like to remind everybody who's attending to please enter your contact information into the webinar attendance form. The link is in the comment section underneath the video. This way we could send you the CE credit for attendance. If anybody has additional questions, you could contact either Blue Sky Bio, or you could contact Armen and his team, and we'd be happy to assist any way that we can. I think we're pretty much out of time, so I'd like to thank you for the presentation, and I'd like to thank everybody for attending. We have another couple of presentations coming up as part of this webinar series, so please stay tuned. And we have a couple of presentations that have already been given, or more than a couple, a lot of presentations already been given, and those could be viewed on YouTube as well. So Armen, thank you very much for this presentation. It's been
Thank
very
you,
long
Michael.
and insightful. And everybody, thank you for attending.
Thank you.